Wow. Good morning, everyone. Thank you. Good morning. Okay, we're slightly asleep, and that's okay. It's an early morning session. We're trying to wake you up here. I'm David Chambers from the National Institute of Mental Health, and am very pleased to be here not only with fellow colleagues from NIH, but also our sort of sibling agencies from the Veterans Health Administration and from the Agency for Healthcare Research and Quality. We really set out on this road a number of years ago, wanting to try and have common dialogue and a common forum where people were, whether they were doing research funded by one agency or another, or foundations or wherever, that they could come together and talk about how to move this field forward. And so we're very pleased that that we have this nice mix of expertise and participation across our federal partnership. I'm going to go relatively quickly and just give you a few points about where I think we are right now in terms of the field and ideally where we can go. I'm going to start out with a few numbers, and these are observations that I was listening very intently. It's nice. Yesterday I just got to sit back and listen, and a few things came to mind, which I thought I would share. Whoops, there we go. Okay, so the first of which is really the growth of the field, marked at least in one way by the amount of participation at these meetings. So when we started this a few years back, we had 350 people. You can see just within a few years, we're now up to at least registrants of 1,200. And the question is, where are we going from here? And it's not only the numbers, but it's actually making sure that we have all of you and then some, right? So I think I've heard comments about how this has become really a wonderful research conference, but what keeps coming up again and again is that dissemination and implementation is not only trans or interdisciplinary, but also involves a great number of stakeholders. And so the question of, who is the right mix is something that ideally we can really think about, and that's where on your evaluation forms or those other kind of things you can help us with some of these issues. The second number is 41, and that was over the first few years of the trans NIH program announcement. We had 41 grants, but I think as we're seeing the growth in interest, the growth in capacity, what we want to see is the growth in the actual applications that are coming in and the actual applications that are funded. We also have heard this discussion of spending potentially 1% of research dollars on this area. And I think with that ideal increase in capacity, increase in interest, also comes an increase in the share of efforts that's devoted to this area. I don't know, the X is true. I don't know exactly what that percentage should be. Maybe you can help us with that. But I think the idea is to see to what degree are we focusing our research dollars on ultimate impact versus all of the steps that lead up to that. The next number really comes from another thing that I think you can all contribute to, and that's this sort of 1/3 rule. There's often this idea that if you take a particular intervention, 1/3 of the people are not going to benefit, 1/3 may benefit no matter what it is, and an additional 1/3 may benefit on top of from that particular intervention. And I think what you all are contributing, knowing what's going on as the interventions are meeting real-world practice, real-world populations, ideally we can continue to move that benefit of any intervention up. And then we also see what historically, the 17-year gap between research and practice, those who have done the studies on it basically said, how long does it take to get 50% of people accessing a particular treatment? And as we've heard from Bob Kaplan yesterday, as we've heard from Russ, the different ways in which we see the degradation of that impact, whether it's in terms of the reach, the effectiveness, and other steps along the way, you're again also in a position to try and maximize that. So we don't, a few years from now, say, we're content because 50% of people are getting a particular treatment that all should benefit from. So just to leave you there, this is not only the progress that we're making, but there's a long road ahead, and we want you absolutely to come with us. This slide, which nobody in the back is going to see, so apologies for that, although I suppose anyone on videocast, I think you've got a better view. But basically what it represented is in 2002, an effort that we had just to try and lay out some of the dimensions of the problem that we're dealing with. And we have the content of the evidence that we're trying to get into play. We have the context in in which care is being delivered, clinical, community, other settings, the process through which we try to make sure that that effective knowledge translates into useful benefit for populations. What I thought I would do in terms of thinking about the sort of funding, because that's obviously where our jobs are focused, is thinking about how does this translate to where we are and where we have come. So with the content, we have been fortunate enough to have pretty widespread agreement across NIH on the value of having a common set of research priorities. With the context, what you're in a position of doing is not only focusing internally on what are the care settings that you're working with, what are the types of practice that you're seeing currently that you're trying to see if one can try and improve, what are the key research questions. On the external side, you have the challenge but also the opportunity to really learn from each other, from the previous research going on, from the policy environment in which any of practice takes place, and the ongoing work that you and others are engaged in. And then the process, which we don't want to lose sight of, particularly from our role, is in making sure that at each step of the way, from concept paper all the way through to review and to a funding decision, that we're in as we on this side are as helpful as we can be. So I wanted to then just move ahead to the sort of where are we right now. And in 2004, several of us at NIH came up with a list of, I guess it now comes down to 7 C's for whatever value that is. But we came up with a list of what did we want to try and accomplish. And I think that we're making some progress, but we absolutely need your investment and your support to make sure that this doesn't fall by the wayside. The first of which was really trying to clarify terminology, to try and have a common set of research priorities, to make sure that there was active research in the area, centralized review, capacity building, a conference as we are here today, and then a channel of accountability. So what we started out, and obviously this hasn't been solved yet, but we didn't want to try and solve it at NIH. We just wanted to say, could we agree upon a set of working definitions? Not even those that the investigator community would have to sign on to, but rather so that we at least internally could speak with similar voices. And so we set out defining dissemination as the targeted distribution of information and intervention materials to specific audiences, contrasted from this notion of implementation, trying to embed, adopt, integrate effective strategies and change practice patterns within specific settings. Those were the definitions that we adopted in 2004, 2005. They're the definitions that we continue to use today, but they're not the definitions that we expect that everyone is agreeing on. I think, as was said very astutely in the panel, the international panel, as long as we know what each other is meaning when we're using different terms. We just wanted you to know what we meant when we chose these particular terms. We also were able to, in 2005, 2006, to have a common program announcement that, as you can see, involved 8 institutes along with 2 of our centralized offices. It had a special emphasis panel, the first time that we had seen across NIH, all applications around dissemination and implementation research going forward, submission every round, and we had 41 funded projects out of that. The funded projects we were gratified to see really did cut across the different types of interventions, prevention, screening, treatment, policy, additional things. It cut across the types of settings, community, primary care, specialty, as well as other. And what was very nice is in the years preceding it, we really had a lot of observational studies. We didn't have much in the way of prospective efforts to try and influence, to try and improve dissemination and implementation. And so it was nice to see that of those 41 projects, the vast majority of them were really focusing on prospective work. And so what was also very nice is that we saw this challenge of how do you improve practice, how do you improve outcomes at multiple levels, the individual consumer patient, the provider, the team, the practice level, the agency, the county, and even the state. We saw RCTs, we saw natural experiments, we've seen observational studies, we've seen community-based participatory research approaches. The diversity of the field needs a diversity of approaches, and it was very nice to see, even in these early days, that we found that. It was again nice to see that we had a whole range of interventions, knowing that at every point of care there are improvements that can be made, and very nice to see that it wasn't a particular flavor of intervention, but pharmacologic as well as psychosocial interventions at different levels were well represented. presented. So we moved along, and what was nice about this more recent PR were several things. First of all, we got a number of institutes and centers to join on. So you can see NIAID, NIDDK, Neurological Disorders and Stroke, and Fogarty joined us. And as we heard yesterday, the importance of the globalization of health, the globalization of knowledge, shows the value of having our global partner within NIH. And a very important thing, we found the ability to have every round submission. So where in the past people had to choose, do the deadlines line up well with my particular question? No longer does one have to choose that. But we still have, at this day, a lot of areas that are ripe for exploration. You can see, and you probably know, those of you embedded in this field, that there's relatively little information about how do you sustain effective practices over time. There's very little focus on how natural adaptation, or as Kurt Stange says, the evolution, the evolvability of evidence-based practices occurs over time. We still have relatively little, and it was nice to see represented in think tanks over the last couple of years, emphasis on scaling up practices at great degrees across health plans, across systems, across networks, and again, evidence yesterday globally. We still have room and certainly an imperative to improve methods and measurement development. And really what people haven't focused so much on is how do you think about not just implementing an individual practice, but thinking about scaffolding, thinking about a broader system of practices, system of evidence-based care, not just you deliver or you receive this particular practice if it happens to apply to you. It was great to see that last fall, what got kicked off was within the Center of Scientific Review, finally a standing review committee. You can see Jacinta Bronte Tinku is the scientific review officer. You'll see a link which you can also just Google DIRH. That'll get you to the same thing. But you can see a link to the roster of the reviewers. And you can see this is a very exciting time for us where you have a study section that is specifically reviewing applications, as you see here, intending to bridge the gaps between public health, clinical research, and everyday practice. Trying to make sure that you transmit and implement knowledge from scientific discovery to transform healthcare delivery, improve health outcomes, and manage acute and chronic illness. So the concept of NIH as being able to expand from basic all the way through the ultimate impact, I think, is borne well by the places in which these applications can be reviewed. With capacity building, we, I think, have a nice, vibrant portfolio that consists of all manners of studies, whether they're the small R03s all the way through the larger R21s, R34s, R01s, R18s, and the RC1s and 2s, which some of you in the audience were able to get from the stimulus funds. We've seen research centers, we've seen specific cores within CTSAs, we've seen networks focusing on dissemination and implementation. As some of you probably saw, there was a presentation describing an R25 that's funded. This is a week-long, actually across a couple of years, training institute for emerging scholars on the mental health side and dissemination and implementation. And as you can see right here, OBSSR has led, and several other of us are involved in trying to do a broader summer training institute, which will be in UNC in August. This meeting, I think, has really, for us, been a wonderful reflection of some of the progress that all of you are making out there, and that we started out by saying we just want to showcase a few of the exciting projects that we see that are going on. And as you can see, even then, when we were doing it as sort of a test case, we had about 350 folks come. And now that we're focusing on policy and practice, now that the field is expanding, we're close to fourfold where we were just a few years ago. And then finally, what's been very important for us is to try and see what are the kind of leverage points that demand not only production in terms of the studies that are emerging, but ideally accountability, so that we know that over time, all of the work that you're doing translates into knowledgeable movement in some of the sort of dials that we see running, or what should be running, our public health system. And so within our department strategic plan, there's actually currently a goal that we're all expected to report on quarterly. And as you can see, it's very specific to 3 key factors influencing the scaling up of research-tested interventions across large networks of service systems. But the important thing about it is it's, I think, the department's recognition that NIH has something to contribute here, and AHRQ has something to contribute here, and other agencies within the department have something to contribute there, and they want us to contribute. They want this goal to be met. They want, in 2015, to be able to say, we know definitively, or at least reasonably definitively, how best to scale up the interventions that we know have been beneficial and we know have been published into as broad practice as we can possibly get them. And so you can see the quarterly reports, you can see annual targets, but it really represents, I think, keeping everyone's feet to the fire. And we desperately need your work to make sure that we meet this goal. It's something that has not, at least as far as I know, happened previously, and it's something that we're excited about, but it raises the game for us just a little bit more. So I just want to say, I feel like we're on a train, the train is moving, and it's time for us to all move along. Bye, train. And just want to say thanks. And as always, I think we're here to answer your questions, but most of all to learn from you and your experiences. So thank you very much.
Well, thank you. If I could have my slides, I'm Russ Glasgow. Good morning. David, I'm not sure that was the new Excella high-speed train that we had there at the end. I'd like to, first of all, thank David. This is the first year that I've really had a chance to be intimately involved with the planning. I've been involved in different ways with this throughout the years, but David's been an incredible partner and a mentor in this, so I just really would like to give him a shout out and thank him for that. One other little bit that some of you might be aware of, in addition to the sheer numbers of attendees, we also set a record. I believe, Helen, we had 3 times the number of abstracts that we've had before. So 3 times in 1 year we jumped that. So some of those who did not, these were peer reviewed. Some of you that didn't get that, so besides yelling at David and me and Helen about that, just realize it was much more competitive this year. In many ways, this is a celebration, and I think we have a lot to celebrate, and you'll hear, I'm going to be brief here so you can hear from some of the other successes here, but I'm going to just jump ahead and off script a little bit just to give a kudos to David and this time the other David next to there, David Atkins, and the VA query program. I think that is today our national success story, actually, in terms of going to scale and making a difference in terms of impact. So I'm glad to see that they are here and there throughout that and that they're partnering with us, and I encourage you all to find out more about that. Okay, despite all of that good news and success that we celebrate, we still have a lot of work to do, as exemplified both by David's 1890s train, but also, if you can see this slide, I don't know if you can, illustrates some of the word salad that we have here on the left. My pointer doesn't seem to be working. But shared by our Canadian colleagues yesterday, and I think we'd have to say we still have a lot of work to do in terms of terminology and defining the field, and you just heard some of that, what is almost word salad. Despite that, I think we have made progress in a number of ways, and I want to share with you some of the things that I heard yesterday, just to provide a little reflection and some of the things that I have heard about. One of them, Dr. Clancy started off talking about PCORI and comparative effectiveness research. I guess I'd like to make a plea to those of you out there that I think this is a very appropriate, very relevant, and very timely area for D&I research. And I really encourage you to think about that, to learn about the definitions of comparative effectiveness, what counts, to be involved in this broad national experiment as we go forward. And to think about framing some of your research as CER. I'll skip the next one. I think that was pretty clear, but just to underline the point about how much we can learn, not only help and assist, but we can learn from low and middle income countries in terms of what's going on there. As you'll hear from our distinguished keynote speaker today, Ross Brownson is going to close up, and that's one of our sub-themes here, policy research. That's an area in which we could do a whole lot more. Not only policy in general, but getting things like guidelines implemented and thinking about policy as a key contextual factor. If I can, the next slide. Just very quickly here, I think there's a huge opportunity. Major advance from my perspective is the consort, recognizing pragmatic trials and particularly the PRACES criteria to talk about in a much more transparent way than we ever have before the extent to which studies and interventions are pragmatic on each of 10 dimensions. I thought Vikram yesterday did a great job. I don't have much more to say about task shifting other than how critical that is, not only in low and middle income countries, but for us here. Again, I think I have commented on those things there. Just close with saying another area we need to continue to focus on with all our exciting innovations is disparities, and disparities broadly defined, so that look at who's left behind, not only who's participating, but who's not and who's left behind here. Okay, moving right along. We still know that today, my slide doesn't work. There we go. The most common type of translation, though, is not T1, T2, T3, T4, but it is this, whatever we call it. It is bench to bookshelf, or maybe bench to journal publication. Thank you. Bench to publication. Still doesn't like my pointer. Bench to bookshelf here. So I would argue that we have pretty conclusive evidence that something different is needed. A little shout out to a recognition to Steve Kaplan, who's here in the audience, that organized, I think just a week ago, it's been quite a month, an incredible meeting on multi-level interventions. How do we understand them? How do we conceptualize them? How do we evaluate them? How do we think about theories for this? And this notion about maybe we need to start something different rather than just dig deeper in the hole we've dug for ourselves in terms of lack of translation. Okay, one thing that I don't have time to talk about, but I'm just going to throw out as a teaser that my colleagues and I have been thinking about here. Believe it or not, it's a little different than REAIM even, for those of you that know me, but hopefully something that might be a little easier to translate or communicate is what we call an evidence-based triangle, or an evidence integration triangle of what, if you'll bear with me, I think might be needed for real success at broad-scale adoption, implementation, and maintenance. And it goes like this. At the top, I think we've done a great job that says intervention, program, or policy. And I think with a couple exceptions, I won't bore you with, that both the NIH and in general, U.S. science has done a great job of identifying evidence-based interventions, a little less so at identifying very robust interventions and policies. But I think we've made huge successes, and we should celebrate that. We know, though, just that by creating these doesn't mean that they get into practice. I'd like to argue or suggest that two reasons that they don't is that that's necessary but not sufficient. One other thing we need, whoops, I did the wrong button, that what we need is practical measures on the right bottom hand thing, and more about that in a moment. But notice I said practical measures, not just research standard measures, which we need, and gold standard, but practical measures that can be used for feedback and ongoing longitudinal tracking over time. And secondly, that we need appropriate implementation process. And what I mean by this is walking our talk. Whether we're talking about being patient-centered, about really using team science, or using CBPR, I'm talking about being serious, not just giving lip service about implementing the principles of this. Okay, enough about that. Here's some opportunities. David told you where the money is already, so at the risk of having you fall asleep and not have any other things about money, I'm going to tell you about some other non-monetary opportunities, but that might pay off for you in many ways, including getting future research grants. One opportunity is that I think is strongly related, going back to my last slide with practical measures here, is there's a trans NIH opportunity going on now in partnership with the Society of Behavioral Medicine to identify a set of brief, practical, actionable, translatable, generalizable measures that could be routinely used in the electronic health record. There are 2 phases right now. This is in the second of 3 phases. I would like to invite all of you, and there will be information. I'm going to show you right up there is the website. We're trying a social media experiment. You are all invited, and invited to your colleagues, and particularly those in primary care, because the focus is on primary care here, to play on this wiki, see what measures are recommended. If you don't like those, suggest some of your own, comment on them, and then there's going to be a national town hall meeting on May 2nd, and I'll be glad to talk with anyone more about that later. But this is a trans NIH opportunity. Second, we're very, very proud and privileged to announce what we hope will be the first annual. I know David just told you this, but I'm telling you again, and there's a table out in back that has information on this training opportunity, a week-long training to interact with world-class and international faculty on D&I, all expenses paid at a very nice facility, week-long training. The application closes, I think, tax day, April 15th, I believe, so we'll make it a double fun day for people. We expect it to be highly competitive, but I think it's a great deal that will hopefully help build the field. I won't go over all of these, but just a quick shout out. David will tell you more about his query training. I don't see Sharon or Jeremy, but can somebody tell me, I didn't get a chance to check this morning, they have an incredible program, and as in many ways the Canadians are ahead of us with their KT training and networking, but I wasn't sure if that was available to US or to non-Canadians. Jeremy or Sharon here, or does anybody know? It is available. Okay, so it is available to a select few. So thank you, and finally, I will move along here. Okay, a shameless promotion for our own work at NCI. We're trying to engage in social media, and my crew and team is dragging Luddite Russ along somewhat, not entirely kicking and screaming, but I'm trying to learn how to use my cell phone now. I noticed at least some of you may be as much laggards at technology adoption as me, because we didn't get many tweets yesterday at our session, but we're trying to move into virtual engagement and a way to maintain, for example, this meeting, so it isn't a one-time event, but so it has some legs to it, and we're certainly going to emphasize that in our training. Again, I think our Canadian colleagues and our VA colleagues have some nice models of that, but I invite you can see the URL here to go. We have monthly cyber seminars, a lot of online discussions, events calendars. We have like radio call-in talk show webcasts that you can do to participate in things. So look for that. We invite all of you. My take-home messages here, 3 things. There is a pressing need for research that, as Kurt Stange has told us, is rigorous, but also that is relevant. And it's quite possible, and you're hearing some great examples here, that research can be rigorous and relevant. It's not one or the other, the way people like to dichotomize things. And NIH and study sections are going to demand that your research is rigorous. It's up to us as a body to demand that they're also relevant. Second point, there is a science. We might not know exactly what we call it, whether it's KT or D&I or implementation research, but there is an evolving science. This isn't just feel-good, trying to help people, but it's also a science. It has some familiar characteristics as are listed there. It also has some new and different approaches. And finally, in terms of opportunities to advance, remember the Einstein slide, we need to be open to new approaches, to things like simulation modeling, to appropriate analysis of observational data, to rapid learning healthcare systems, from ever-increasing EHR data to things like community health indicators that are available. So we need to think differently and get out of our same old ruts that there's only one approach to truth. At this, I have a little thing that, Helen, I could use your help on. If I could call Helen Meisner up to the stage to help us here. But I do want to stress again that, come on up, that we really do take seriously your evaluations. We may undergo some changes. We're kind of at capacity this year. So the reason I asked Helen up here for my last and final slide is we have an award. This award was, as you heard, Helen was appropriately recognized by the NIH top of the hierarchy, but we thought it only appropriate that she also be recognized by her family here, and she really has been mom for all of us and for building this over the years. This particular award was initiated by my colleague Brad Hesse at NCI, who we unofficially call the punster, and I'll let you figure out the punster there. But this is somewhat like a Lifetime Achievement Award for dissemination and implementation research, and it's also interesting that we have, this is only the second time it's ever been awarded, so we have a plaque here for Helen, very nice one, the Glasgow Award, and it reads, for her exceptional work and contribution to the science and building the field of dissemination and implementation. So, Helen, congratulations. And
I thought you wanted me to come up and collect evaluations.
well, you can tell them about that, as well as in a minute if you would like to say anything. But I do just have to note that I said this was the second occasion. We're also honored that the original co-recipient of the award, Dr. Leif Solberg, it happens to be in the audience attendance today, was the original, the recipient of this. And Leif, you'll know that over time we have developed a little bit more truth in advertising. So in fact, today, we also do have a glass cow for Helen to award to go with her plaque.
Thank you.
If you'd like to say anything.
Thanks, Russ. I think I'm speechless. This really is a very nice acknowledgement and very sweet of you, but really the kudos go to all of you for building the field, and especially to my colleague here, David Chambers, who's really led the efforts at NIH. And also, it's been a real thrill to have Russ, the real, you called me grandma, or mom, you're the grandpa here. And it's just been fantastic to see how this field has really just taken off. And I really look forward to seeing where we all go with it. So thank you.
Wow, good morning. And congratulations, Helen. That was fantastic. I have to say, that was a wonderfully surprised look on your face, Helen, when you were expecting some conversation about evaluation forms. Hard to follow that. Good morning. My name is Francis Chesley. At AHRQ, I direct the Office of Extramural Research Education and Priority Populations. And I'm pleased today to have an opportunity to talk about AHRQ's funding opportunity as it relates to dissemination and implementation research. I know you saw this slide, I'm sure, yesterday from Carolyn, but I will also show it again just to remind you of AHRQ's mission, which is to improve the quality, safety, efficiency, and effectiveness of healthcare for all Americans. And our vision, along with this mission statement, is that as a result of our work, and I would dare say our work in collaboration with other folks across the healthcare sector, the American healthcare will provide services of the highest quality with the best possible outcomes and at the lowest cost. So at AHRQ, speaking of funding opportunities, at AHRQ, our budget appropriation really comes by way of our research portfolios. And this circle just really is meant to describe or to list those, from comparative effectiveness research to patient safety, health information technology, our value portfolio, which you might think about as quality with cost considerations, prevention and care management, that's where a lot of our clinical research is apportioned, and this portfolio, which we call innovations and emerging areas, a portfolio that tries to take advantage of opportunities to move the needle quickly from an innovations perspective. So the first take-home message for AHRQ is that while Congress appropriates our budget across the portfolios, our research budget is also apportioned for general grant funds as well. And the general grant funds are often the funds, in addition to dissemination and implementation research that's funded across the portfolios, is often a bucket of funding for research applications that are focused in dissemination and implementation. I'm going to come back to that in a moment. This slide really is just meant to integrate those what seem to be kind of static portfolios to give you some general list of priority topics for AHRQ, whether it is patient safety. And you'll notice right away, just by one example, I've got health IT listed under patient safety. And while patient safety and health IT are separate portfolios that enjoy separate funding and have separate outcome measures that are tracked by not only the department, but OMB and others, it is in fact a nice integration between the use of of health IT tools in the patient safety context to improve quality. So I wanted to mention that just by way of an example that those portfolios, while they're each distinct, there is quite a bit of synergy across them. So what's AHRQ's focus on implementation science? I do want to take a trip back historically first before I get to this and say that when the Agency for Healthcare Policy and Research was authorized by Congress, that's AHRQ's predecessor organization, it impaneled a study section which we called the Healthcare Dissemination and Implementation Study Section. That was one of our first study sections, and it was in recognition of the fact that one of AHCPR, one of AHRQ's main priorities was to sort of focus and fund research on dissemination and implementation. For us, it predated our current construct of what we know about T1, T2, T3, et cetera, hopefully not bench to bookcase, but we know about that as well. So we started that study section, and over time, we began to integrate dissemination and implementation across the agency's work, across its portfolios, so much so that I would say 6 years ago, we kind of did away with that study section and rather integrated dissemination and implementation across our study sections. So lo and behold, I was chatting with David Atkins just a little bit ago before we got started, and he asked me if we had a study section that focused on dissemination and implementation. And the short story now is we've recognized that by sort of integrating those research projects across our study sections, we've lost something, and that is our study section's ability to focus on those applications, considering both rigor and relevance, so much so that we've now started another study section, which is going to be sort of a mirror to our dissemination and implementation study section, but will be the study section that much of this work will go to. So at AHRQ, circling forward, what's our primary focus? Our primary focus in implementation science research is advancing the science of how organizational structure, process reengineering, and behavioral incentives can improve outcomes, improving delivery system performance on quality and other outcomes, advancing implementation and spread, and best practices to improve healthcare quality. I want to pause there because as we have evolved, the end game for us, as is sort of encapsulated in our mission statement, is ultimately improving healthcare quality. Reducing disparities in healthcare delivery and outcomes through interventions such as those focused on health IT, cultural competence strategies, and in particular, a focus on settings, the settings in which folks get care. So for grantees thinking about AHRQ as a funding agency, what are some of the essentials? Well, first and foremost, we think it's critically important to involve stakeholders, to involve those for whom that research is meant to ultimately help in intervention development, as well as actually in the study design and even conduct of the study, including a clear set of quality outcome measures, presenting a complete implementation research study plan, use of rigorous research designs. I'll say that at the same time, we also think it's important to take some risks. We do think that our peer review groups have learned to account for some risk-taking in implementation and dissemination research while it is looking at the relevance and rigor of the research design, or for that matter, the analytic plan. It's important to anticipate problems that may pop up in the research, and quite honestly, in your research proposal, it's a good idea to address those potential problems because that's where oftentimes study section members gravitate to first. We think it's important to select an analytic plan that is appropriate for the aims and design of the research. Use consistent theory and logic models. Now, I'm going to pause here and also take a trip back historically. So move forward from AHCPR, I guess we're close to AHRQ time. This is 1998. AHRQ published one of its first funding opportunity announcements. We called it Translating Research into Practice, the TRIP initiative. It went on to spawn TRIP 2 and TRIP 3. After the first announcement, we recognized that others within the federal healthcare sector were also focusing research in this area, and the VA was one of the leaders, as you'll hear in a minute from David Atkins. So one of the things that we did for AHRQ, this was a first. We have a very strong track record of collaborating and co-funding with the National Institutes of Health, but this was the first time we funded a TRIP, a Translating Research into Practice funding opportunity announcement with our colleagues at the VA. It was no small feat to pull two sort of grants administrative bodies together and come up with a funding announcement that would divvy out applications. Central themes, applications going to AHRQ and the VA, quite successful. It underscores the importance of collaboration across the federal sector here. So I want to just now transition to a couple of announcements that I think are important to think about as you think of AHRQ as a funding source for dissemination and implementation research. Generally, we see a lot of these proposals coming in response to our general R18 Demonstration funding opportunity announcement. But we also, thanks to Denise Doherty, who is the brainchild of the Researching Implementation and Change While Improving Quality, have a funding opportunity announcement that we think is focused squarely on implementation research with the end game being quality improvement. You'll also see other funding opportunity announcements from other portfolios, improving patient safety, prevention and care management, and the use of health IT. And we also have had a strong track record of using our conference grant mechanisms, either the small conference grant announcement, which funds annual conferences at $50,000 or less, or the large and recurring funding opportunity announcement that funds large research conferences at $100,000 per year. We've been able to fund conferences focused in this area as well. So before I go back to the R18 that I mentioned before, I do want to also provide a couple of links here, which are training and career development announcements, which are relevant for funding of what we call the next generation of health services researchers who want to do dissemination and implementation research. We fund dissertation applications, but particularly our career development awards have proved to be very nice ground for future researchers to get protected time covered and research projects that focus on implementation. I just mentioned this one, so I'm going to skip through that one. Actually, let me go back because I think I skipped this slide. Yeah, so this is what I want to focus a moment on. So this is our R18 Demonstration Funding Opportunity Announcement, which is focused on implementation and change while improving quality. And I just want to highlight a couple of features of this one because this is, I think, for AHRQ, one of the funding opportunity announcements that squarely focuses on dissemination and implementation research. And again, this is a theme that you've heard before, implementation of quality improvement interventions, focusing on quality improvement, obviously, focusing on the way that healthcare is paid for, organized, and delivered. And what I'm trying to do with this slide, as well as with my brief comments, is sort of draw some distinctions between other funders of dissemination and implementation research so that you can see that if we're getting it right across the federal research funding sector, we've got the waterfront covered in terms of funding for dissemination and implementation research. Here at AHRQ, and in this particular announcement, one of the most important features for applicants is to be very mindful and specific about the context of these quality improvement interventions, which are designed as interventions to improve quality. So lastly, Russ touched on comparative effectiveness research. I know Carolyn talked about this and mentioned the Patient-Centered Outcome Research Institute. Well, we're very fortunate that the Affordable Care Act, as Carolyn mentioned, established the Patient-Centered Outcome Research Institute. And that institute will eventually be up and running and funding research, comparative effectiveness research, within which I couldn't agree more with Russ that dissemination and implementation research is fully a component of that. At AHRQ, we will be funding research and training and dissemination as a result of this piece of legislation with funding that comes directly to AHRQ from the Patient-Centered Outcome Research Institute. And here, I've listed for AHRQ what are the priority funding areas that will be funded as a result of PCORI in the area of comparative effectiveness research. If you read the legislation, and I wouldn't read all of it, but if you read the one page, it's just one page of a 900-page piece of legislation that focuses on AHRQ's role, you'll see that our Office of Communication and Knowledge Transfer is the focus of this component of research. It's not our comparative effectiveness research portfolio, it's the Office of Communication and Knowledge Transfer, with a mandate for AHRQ to focus its CER investments around dissemination and implementation. I'm not going to read through this list completely. I will point out that in addition to dissemination, in addition to methods work, we're called to put together what I'm going to call data repositories, which will be fertile for researchers looking to do research using these data. And perhaps most importantly, from my perspective, I run the training and career development programs with Karen Ruzinski, who's here. Perhaps most importantly, from our perspective, it funds annually training for the future researchers in patient-centered outcome research and provide some stable funding, and will give us an opportunity actually to be a little more innovative in how we fund training in patient-centered outcome research or comparative effectiveness research. So I can't get into much more details about the specifics of that funding, but I will say stay tuned. AHRQ is very much a sister agency with NIH and how it uses grant mechanisms and how it advertises its grant announcements. We use the NIH Guide. It's the best thing going, and so we publish all of our grant announcements there. Looking forward to an opportunity to answer questions. This is my contact information if you need to get in touch with me. And we'll hear next from David Atkins. Thank you very much.
Thank you. So I'm going to try to do three things in a relatively short time. One is to talk briefly about VA funding opportunities. The second is to try to sell the VA as a great place to study implementation for those of you who are earlier in your careers and looking for a home. And then lastly, to reflect a little bit on what we've learned in trying to do this in the Query program for over 10 years. The great advantage of the VA as a research place is we are a healthcare organization, and with the exception of those of you who work for Kaiser or Health Partners or Group Health, it's a unique opportunity. The challenge is that since you're working in a healthcare system, you're expected to deliver on the promise of research. And I use a joke with our researchers of, how many implementation researchers does it take to change a light bulb? And the answer is, well, that's not our job. That's the job of the healthcare system. And if you talk to our partners, that's not how they see it. And so I'll talk a little bit about the challenge of the elevated expectations of translation research. So the caveat about VA funding is it's an intramural program. So those of you who are lucky enough to work in the VA, you've already heard this before, and you can go back to your BlackBerries. Those of you who aren't in the VA, you can't get our money, so you can go back to your BlackBerries. But for those of you who are looking for a home for research, come join us, because I'll try to say that this is a unique place to do translation research. And of course, we do rely on research colleagues on many of our research projects. And we have also benefited from NIH and AHRQ funding for our research because we have a great system to study translation and sort of unprecedented data systems to allow us to measure a variety of impacts. So the other point I want to make is, to outsiders, the VA looks like a monolithic system, but really it's a very heterogeneous system. So within the large healthcare system that serves 5 million veterans, there are 21 networks, over 150 medical centers, over 700 community-based outpatient clinics, which may be as small as one primary care provider to several providers, often in very rural and remote settings. So we have the whole distribution of healthcare settings represented within the VA, large tertiary academically affiliated institutions to small rural hospitals delivering a much more limited set of care. And we have the challenges that many of our veterans are rural and have trouble accessing care, and we need to find ways to meet their needs within this healthcare system. So there are several ways in which we support implementation research. So I am within the Health Services Research and Development Program within VA, which sits within our Office of Research and Development. So within a $570 million budget for research, Health Services Research gets a little under 20% of that, around 97 million. And we do fund implementation research studies. Recently, a focus on things like health systems research, system reengineering, but we do have a specific portfolio for health systems research and implementation research. But I think the more interesting thing, because I'm the head of it, is the query program, because that specifically was designed to try to focus on the implementation challenge in 9 high priority areas. And it was set up about 10 years ago as part of larger reorganization within VA, and that gets $18 million. And the interesting thing about it is it gets money actually from the medical care side, not from the research appropriation. And that's a good and a bad thing. It's a challenge in that it creates clear expectations because that's money that could otherwise go to hire nurses, go to hire suicide prevention counselors, and so it makes it clear that we're supposed to deliver on that. And it's a good thing because I can use that leverage to press my researchers to say, you know, it's not good enough to study something that you think is interesting to your academic colleagues. I need to be able to show why they should continue to invest in us because you're helping to improve care for veterans. And I think that's important. And lastly, we have a career development program, which is, again, I think a unique, it's not unique in that it's similar to sort of K Awards and NIH, but it's a great program. We rely on it to build our next generation of researchers, and I'm hoping to expand the focus of career development to include implementation research. So this is just a distribution of our query coordinating centers, and I'll translate some of the acronyms to show that the areas we focus on are the typical kind of chronic diseases that are high burdens in our elderly veteran population, like diabetes, stroke, ischemic heart disease, heart failure. There are behavioral issues like substance use, mental health, HIV, HCV, and then there's some specific VA veteran-specific issues like polytrauma and spinal cord injury. And then lastly, we have a resource center called Cypress. I encourage you to stop at the table out there, headed by Brian Mittman, who unfortunately had to go home to tend to flooding in his Los Angeles home. But that's meant to serve all the query centers, but also to promote implementation science as a discipline. So the types of funding we have, we supply infrastructure support to our centers, and the important thing about that is that a lot of what has made query effective has been the relationship building between the researchers and between their partners on the healthcare side. And that infrastructure funding also allows support of small local projects, pilot projects. It supports analytic support, IT to work with our data systems. We do a lot of our funding through small rapid response projects, which last up to a year and are up to $100,000. And those focus on things like formative evaluations, assessments of feasibility, barriers, and facilitators. And we review those in an expedited way so that we can respond more quickly to issues that emerge on the healthcare side. And we don't have to go through the typical sort of year-long process of getting proposals written and reviewed. And then we have service-directed projects that are meant to take ideas more to scale and look about spreading within the VA system. Our implementation projects run a gamut from single-site demonstrations to take a implementation intervention, look at it in detail within one site, and then we try to spread that to looking at multiple facilities, perhaps within a region, with an aim towards getting to larger rollout that will involve several different regions with a greater diversity of settings. I wanted to highlight one thing here, which is what we call hybrid studies, which is a recognition that sometimes you have an intervention that has been proven to work in one fairly limited setting. And then the question is, do you now go and do an effectiveness study to prove that it actually can work in a more real-world setting? Or do you study implementation, which is how do you actually deliver it and spread it? And so a hybrid study is a study that recognizes you really need to do both. So rather than saying, let's wait for the effectiveness study to prove that this can actually work, we say, you know, we think this is promising enough that we ought to roll it out, but at the same time, we ought to verify our assumptions that it's actually going to retain its effectiveness as you implement it. So, but recognizing that we need to study the implementation process as well as testing the sort of summative evaluation of how effective it is. So I put this pipeline up in part just because it reflects in some ways some of what we've learned about the limitations of our model. So this was a pipeline about how we build things to scale with the assumption we're going to turn it over to the VA healthcare system for national rollout. And I think the problem with this analogy is it sort of assumes we hold the knowledge and we push it out this pipeline to these sort of passive receptors. And in line with Leif Solberg's comment yesterday, I think we increasingly are thinking about partnered research or participatory research rather than simply us translating stuff for these simple-minded clinicians who don't keep up with the science. So I'll just close with some reflections on sort of stumbles along the way. One is that the key thing is that we've heard already, you have to start with the questions that are important to the healthcare system. And we've learned, initially we made the mistake of being too much like health services research. We learned to focus more on implementation. We learned to bring theory into it, but I think we still struggle with having the theory serve the purposes of learning how to do things effectively. Sometimes we see researchers adapting the questions to fit whatever theory they've chosen, or picking a theory off the shelf and sort of grafting it on top of their study. And we really need to think about how theory helps us learn not just to describe what's going on, but to actually make our implementation more effective. So I'll close with these lessons. I think the VA has advantages as an integrated health system, but we have the same challenge of bringing researchers and our stakeholders together and having them think about, understand their different incentives and their different limitations. We've used anthropologists effectively to even understand that culture of how things change. I've mentioned we need to think really about participatory research, and I think we're bringing a lot of what we learned from Query into our health services research, and recognizing that health services research needs to begin at the beginning thinking about implementation. So even as they're doing initial efficacy studies, we ought to be thinking about implementation issues, learning more about implementation at the beginning of our studies. The last thing, which I think is the biggest challenge, is that research needs to be more nimble to respond to the changing environment. The healthcare system isn't waiting for us to tell them how to implement things. They're making changes, and especially in a place like the VA, they're making wide changes. We're implementing a $250 million conversion to patient-centered medical home. They aren't waiting for us to tell them how to implement it. And so we need to learn how to respond and help them learn while the train is already moving. And we need to finally think about implementation as redesigning rather than adding work to the system. So we're at time, but I'll just close we think of translation as this top picture, this big superhighway, this bridge that's going to take us to the shining city. Sometimes it's really this shaky bridge, the guy down on the left, and sometimes it's just a single guy trying to ford a stream with a moose on his back. And if we recognize that, maybe your work won't always seem so daunting.
So the opportunities abound and the challenges are immense. And now we have just a few minutes for questions. So if anyone wants to pop up, and really time is ticking, so if you really do, then please pop up and ask us questions. As always, we're certainly here afterwards and at all times. And here's a question.
Thank you for the opportunity. I'm Grace Willard from the University of Texas Health Science Center at San Antonio. Can you hear me?
Somewhat, I think.
Okay. Just trying to be heard here. Grace Willard from the University of Texas Health Science Center at San Antonio, and I'm the person with the moose on the back. My question has to do with the idea that throughout this conference so far, we've heard almost every presentation has said something about developing a controlled vocabulary or terminology that fits into all the things that we do in the research. So as the person with the moose on the back, which relates to me in developing terminology, I'd like to ask two questions. One, what can we do to perhaps get some funding from either source to help do that? And has that question been discussed at any level within the AHRQ or NIH?
Okay, good questions. And does anyone?
Yes, I think the best thing you can do immediately as an individual grantee is not to worry about it. We may get 4 or 6 different answers among the 4 of us here, but people are working that out. If you're heavily engaged in it, you can do it, and I don't know, I'd say first talk with Jeremy Grimshaw, which I'm going to do, who, if you didn't catch it, said yesterday there are at least 6 international groups already working on this. So I don't know that we need a 7th or a 10th or a 12th that'll probably come up with different ideas. I would say look for the commonalities, and there are a lot there. Same way with many of our models. There's 90% overlap. Look for the commonalities and what the lessons learned and things are there, rather than worry about the minutia. It probably benefits you to take something. If you're applying to NIH, it probably makes sense to use the NIH definition. If you're applying to AHRQ, it makes sense to use the AHRQ definition. If you're applying, to CIHR in Canada, to use their definition for now. But I wouldn't worry about the real details.
Yeah, and I think the one thing that we really do hope is that whatever terms you're using, that as you're talking about this field with colleagues, that you at least try and define what you mean. I think one of the problems is we often throw out terms and without definition, it's unclear whether we're even interpreting what each other are saying in the right way. And so whether you chose the particular definitions that we started out with, or you chose some of the terms and definitions that you've heard over the last couple of days, we at least hope that the dialogue exists where there's shared understanding of what you're trying to get across. Okay.
We better end.
Okay, I think we're going to end because right up here is going to be the next panel. So please do fill out your evaluation forms, and please do let us know if you have any other questions. Thanks.